So I'm very glad to have with us Nicole Woods, who is one of, well, she has an expertise in cognitive integration, which I've been talking about, that has been an effort in all different ways. We want to improve our way of teaching medical sciences. So Nicole Woods is currently at actually, you're at University of Toronto. She's in the Institute of Health Policy Management and Evaluation. She is currently a scientist at the Wilson Center and associate professor at the Department of Family and Community Medicine. She has a PhD in cognitive psychology, which her primary interest is in human memory. For the last 10 years, she has been trying and clearly proposing new ways of understanding the integration of basic and clinical sciences and clinical reasoning. She uses theories from cognitive psychology to understand the mental processes and structures that underpin the expertise across the health professions. And just to mention some of the most relevant work she has published, she has one published several years ago, which is entitled Science is Fundamental, the Role of Biomedical Knowledge in Clinical Reasoning. She has another paper, which is entitled The Value of Basic Science in Clinical Diagnosis, Creating Coherence Among Signs and Symptoms. Also, the value of basic science in clinical diagnosis. Another one is entitled Cognition Before Curriculum, Rethinking the Integration of Basic Science and Clinical Learning, among many others. So without further introduction, I allow you to hear your talk, and thank you again, Nicole, for sharing your experience with us.
Great. And thank you, Belinda, for that lovely introduction and for inviting me to share the work with you all today. I'm going to see if I can get my screen to share here. And you let me know.
Yeah, we can see them all. Thank you.
Okay, so hang on, sorry. It just did something a bit weird, which it was showing me the wrong way. Okay, so hopefully now you see the big face on the screen. Awesome, okay.
We do, thank you.
Great. So again, thank you for the introduction. So my plan for today, I'm hoping, is to share a little bit with you about the work that I've been doing, and I'm trying to frame this in ways that I think are most helpful to educators in general. And so the challenge of understanding cognitive integration, and more importantly, the challenge of achieving integration in our medical school curricula, it becomes complicated because I suspect there are a lot of things that as educators, we just haven't thought through properly. And so what I'm going to do today is, yes, I'm going to share some of the science, but I also want us all to reconsider and rethink what we mean by integration, and also rethink some of the things that we all assume are true about education and about learning. Because I firmly believe that we have a tendency, just as human beings. So I come to all of this as a cognitive psychologist. So my background is not in education. It's in basic human cognition. And I think one of the commonalities across basic humans all around the world is that we have a tendency to hold to be true premises that we can be really, really confident about and feel very, very strongly about, but be completely wrong about those premises and those assumptions. And so what I'm hoping to do today is encourage you as teachers and as faculty to rethink a lot of things, particularly around basic science, but also to just take a moment to take a step back and think about what are some of the things that you often believe to be true about education, about the way your students learn, and what could you possibly be wrong about. And that's why I've kind of titled this Rethinking. So it's taking a step back and reconsidering. I could have said reconsidering, but it really is rethinking, starting from scratch and thinking all over again about the integration of basic and clinical sciences. So I'm going to start by talking about some things that we all know to be true. And so one basic premise that everybody in health professions education pretty much agrees on is that the basic sciences are essential, right? I feel confident saying that this is kind of a global truth that we've all adopted, because most of our programs, doesn't matter where you are in the world at this point, most of our medical school programs do require extensive training in basic science, right? We hire basic scientists as part of our faculty. The expectation is that science is going to provide a good chunk of really foundational knowledge that our students need to proceed in medical school. But more importantly, we firmly believe that the basic sciences are needed for clinical practice. If we didn't all kind of know that that was true, then you wouldn't even invite me to speak today, right? It wouldn't even become an issue. So this is kind of a fundamental thing that we all agree on and that we all as educators in medicine know. Basic science is essential. We also know that basic science is constantly changing and the science of medicine is rapidly advancing. And this is something we kind of, right now, when I talk about this, people think I mean like artificial intelligence and rapid changes in genomics. But honestly, this idea about basic science advancing has always been part of our scholarly conversation in medicine. You can go back into like the 1800s, 1900s. Everyone's always saying science is moving so fast, right? So we generally believe that science is moving quickly and that we as educators have a responsibility to make sure that our students are able to keep up, right? Keep up with the scientific advancements. One of the reasons we include extensive basic science in our curricula is to prepare our students to be able to participate in that scientific conversation. There's often heavy competition to recruit some of the best and brightest basic scientists in the hope that the school will be able to keep up with the pace of scientific advancement. So we all agree that scientific knowledge is advancing and that it's not a static thing. But there's also some things, and we're all very honest with ourselves today in this conversation. Hopefully we will be. I think there are also some things we don't really know. So when we really think about it, we don't know how much basic science is appropriate for medical students, right? So the how much question is my favorite question in all of medical education. How much basic science do you need? And at my school, I don't know what curriculum committee, if you have equivalent of like a curriculum committee or a school, but we have a curriculum committee. And so the curriculum committee, it turns into this really weird argument about how many weeks of basic science do you need? How many weeks of biochemistry do you need? How many weeks of this course? And so it's a funny thing when I came into this field from psychology, but medical education, for some reason, we've decided to quantify knowledge by how much time you spend in the classroom. It's a really weird way. In psychology, that's not how you quantify knowledge. But truthfully, we don't have an answer about how much basic science do we need, right? Is 6 weeks enough? Is it 6 years? Is it people have to have an entire undergraduate degree in the natural sciences before they enter? We don't really know how much is appropriate. And unfortunately, the answer sometimes just turns into whoever's loudest at curriculum committee. Like if you have a really aggressive biochemistry course director, then you're going to land on, we need a lot of basic science. We need more basic science, seems to be the answer a lot. We also don't know when, and Belinda and I were just chatting about this, is when is the best time for basic science instruction, right? We tend to assume that basic science has to happen or has to be taught in the first few years of medical school or prior to entry in high school, whatever. But there are a lot of questions now about, isn't it more appropriate to also have basic science content in the 3rd and 4th years, during clerkship, during residency, during continuing in medical education? What's the best time for basic science instruction? And most medical schools right now are under a lot of pressure to get students more clinical training as early as possible. So we have programs where students are expected to just get right onto the wards the first day of medical school. As we get more pressure to include more clinical content early on, what happens to the basic science content that's displaced, right? When are we going to cover that content? And this is an answer we don't really know. We don't know when is most appropriate. The biggest thing that I think we don't question overtly, but we do kind of question subtly and maybe unconsciously, is we don't know why. What is the point of all of this basic science content to begin with? Yes, we have to include it. We know it's supposed to be good, but if we really, really push ourselves, do we really understand why we need it in the first place? When we ask practicing physicians, how often do you use your basic science content in everyday practice? They always claim they don't use it at all, right? right? So I often have physicians say to me, you know, why do they have to spend time learning the Krebs cycle? Why do they have to learn this? Why do they have to learn that? The assumption is that they don't use it as often as we seem to think that they should or that they do. So if they don't use it, why are we teaching it to begin with? And so I've been using this quote in a lot of my presentations lately. It's one of my favorites. It's really old right now. It's from J.C. Meekins from McGill University from 1937. And I'll read the quote up for you. So he says, the majority of students naturally think of the individual patient and his illness as the important goal. Therefore, they're inclined to find the meticulous study of anatomy, physiology, and biochemistry rather boring. They think their study a waste of time. To what extent has the teacher of medicine or surgery or gynecology and obstetrics employed the knowledge, language, and techniques of these subjects in the teaching of his own? And the reason I keep getting a lot of use out of this 1937 quote is because I think you could very easily find someone who would say this today. Students today generally think my goal here is to learn to take care of patients. The time I'm spending learning biochemistry and physiology and all these pieces feels like a waste of time. Right? So even though we've been structuring our medical education programs in a very similar way for over 100 years, it's not clear that anybody really understands why this form of knowledge is important. And yeah, that doesn't mean that we don't feel very confident and very strongly that knowledge of science is important. So my colleague, Cynthia Whitehead, spent some time looking through the literature, and what she found is a recurring discourse that knowledge of science is considered the foundation of being a good doctor. We see this in literature again and again and again. And even from a lay standpoint, if I were to tell you, you know what, I'm going to send you to this outstanding cardiologist. By the way, he failed all of his biochemistry courses in med school. I don't think you'd want to see that cardiologist. Just I know I wouldn't, right? So there's a sense from a lay population that science is important. We see this recurring theme in the literature that science is important, but we also constantly question why and what is it doing for us. Teachers, however, it's more important to think the lay population is one thing, but for teachers, this represents a constant battle. This constant battle between basic science teachers and clinical teachers who aren't quite certain what's the role of basic science. So I have here just kind of a basic question. What's the function of the proton pump in the stomach? We have to decide as educators. So here's a basic science question. We need to know, should this topic really be included in the undergraduate medical curriculum at your school? Does this matter for practice? Is this something we need to spend a lot of time on? And I chose this example of the proton pump not at random, but because it was actually used in a study. So they asked a group of basic science teachers and clinical teachers this exact question: should this topic be included in your school? The other thing they asked is, okay, well, should it be included? Yes or no? Most people say, yeah, okay, maybe. Not everyone, to be honest. A lot of people do say no. But then the other question they ask is, by graduation, should a student from your program have ready knowledge of this topic or just be able to recognize the correct answer? So this is our kind of how much, right? So yes, maybe they need to know a little bit about it, but how much do they really need to know? Do they need to understand it in depth or just recognize the correct answer? And when you send these types of questions out to both basic science teachers and clinical teachers, it gives you a sense of what they believe is the required breadth and depth of basic science knowledge. And what they found, so this is a study by Cohen's and Ale Tenkat back in 2006. And what they found is when they sent out a series of these questions, so that was a basic science question, they also had clinical questions. What they found was that basic science teachers and clinical teachers agree on the required amount of clinical content that medical students needed to have at graduation. So whenever the problem, like the question was a clinically related question, both the basic science teachers and clinical teachers agree. Yes, this is important, and yes, they agree on the amount of depth. However, when you ask about basic science content, what you find is that basic science teachers judge that at graduation, medical students should have deeper knowledge. So they always say you need more, right? They need to understand this a lot better. Whereas clinical teachers almost always say that there should be less, right? There should be less basic science. We don't need that much. You don't need that much depth. At the very least, maybe you just need to be able to recognize the correct answer, but you don't need in-depth understanding. So what we have here are two groups of faculty, basic science faculty and clinical faculty, who have a fundamental disagreement about what we need in medical education. You might think to yourself, well, the basic science teachers, how would they know? They don't know anything about medical practice. If you give basic science teachers a chance to actually observe on the wards and have a chance to get into medical practice a little bit and see what's happening, many basic science teachers become even more convinced that you need as much basic science as you can in the curriculum. Similarly, clinical teachers, as they get further along in their own teaching practice and they get further and further away from basic science teaching and further into clinical teaching, they become even more convinced that you need less basic science. So as we give everyone exposure to the realities of clinical practice, both sides become even more convinced of their original position. So the question is, who's right? Who's right in this battle? Who's right in this argument? And I would argue that both sides know something that isn't actually right. They both know something that isn't really so. They're both wrong, really, when push comes to shove. Despite being clear and despite being certain, they are both very, very wrong. And I'm going to explain how. So I think the challenge that we have in medical education is that we often make assumptions about the world as opposed to testing them out. This question about the role of basic science, as far as I'm concerned, this is a scientific question. And we can answer this question by actually conducting experiments. So I'm going to run you through one of the experiments that we did to tackle this exact question. What is the role? What is the value? Is there value in basic science instruction for helping students learn clinical diagnosis? So what we did was we randomly assigned students to one of two conditions. These are students who are coming to us from our undergraduate medical program at U of T. They're assigned to learn both neurology and rheumatology materials. So they're learning 4 different conditions from neuro and rheum. Students could be randomly assigned to the basic science condition or the featureless condition. In the basic science condition, they learn the 4 categories of disorder, and they learn a basic science explanation for each and every feature. In the featureless condition, they learn the same 4 categories, but they don't actually learn any of the basic science mechanisms. They just learn the features of the 4 conditions. The students participate in this experiment outside of class time, so this isn't part of their class. And what's really important here is that they do the experiment by themselves on a customized computer software. The computer is just presenting them lecture slides and an audio recording. So the intent here is to test the content. These are very boring lectures, okay? So I'm not interested in whether the basic science is fun. I'm not interested in whether or not the lecture is fun. I guarantee you it's not intended to be fun, right? But the point is to test the value of the content. So they're allowed to spend as much time as they want studying the 4 disorders. They usually spend about 20 minutes doing that. Then they complete a series of measures, quizzes. So the students in the basic science group take a basic science quiz that makes sure that they did learn the basic science. This is important because it is a boring lecture, so who knows if they're actually listening. So this middle part is really just to make sure everyone's listening. They then complete, in the featureless group, they complete a quiz on the features. Everybody does the same recall quiz, which is a basic memory test. And then they complete a diagnostic test. The diagnostic test is important. So this is where we give them a series of cases and they're asked to select the most appropriate diagnosis. The students then go away for a week. And as I mentioned before, this is outside of class time, so there's no reason to expect them to study or cheat. And then they come back and they complete a novel set of diagnostic cases that they've never seen before and a series of new quizzes that they've never seen before. And the data I'm going to show you here is from the diagnostic test. Sorry, hang on one second, my apologies. Okay, sorry. I don't know what's going on. Someone's banging on my door like crazy. So the data I'm showing you is from the diagnostic test. And what you see here, I want to draw your attention to the performance on immediate testing. So what we see here is that our 2 groups perform exactly the same. So this is their performance right after learning, and there's no difference between them. This is important because this is where I'm telling you that our basic science teachers and our clinical teachers were actually both kind of wrong. So what this tells me, the fact that these 2 groups are performing the same, tells me that you don't necessarily need the basic science in the same way that we might have been thinking. Here, our group that didn't have any basic science at all is performing the exact same as the group that had the basic science. However, the important piece comes when we ask them to come back a week later. When they return after the 1 week, this is our delayed performance, what we see is that the students in our basic science group are outperforming those in our featureless condition. So what this tells us is that the basic science did have value. It had value in helping the students maintain their diagnostic performance over time. So can I learn to diagnose these categories without the basic science? Of course. Can I maintain that mental representation over time? No. So what this tells us is that integration of basic science at the time of learning can help us retain our diagnostic performance over time. But that's not the only role of basic science. So if it was just the case that all the basic science did was help you remember better, I could probably find a pretty easy surrogate for that type of knowledge, right? I could find other ways. I could invent elaborate mnemonics. I could provide people with online easy access just-in-time learning, right? So it has to be able to do something more than just serve as an elaborate memory device. And so what we looked at is whether or not basic science can be useful as a scaffold to help students acquire new knowledge, because that's really what we thought it was doing all along. You have to start with this foundation so we can build, right? So we wanted to test this in the lab as well. So what we did in this experiment is we adapted, this is the design here, we've adapted it from another group called, another two authors, Bransford and Schwartz, who've done work using what we call a double transfer design. And so in this instance, what we did was we took our materials, so we're repeating some of the materials. The students are randomly assigned, again, these are undergraduate medical students, to one of two conditions. This time they're being asked to learn 4 general categories of neurological disease. So upper motor neuron lesions, lower motor neuron lesions, just big bucket categories. The students in the basic science group learn all of the features of the 4 categories, and they learn the underlying basic science mechanisms that explain why those features occur. The students in the clinical science group, they learn all of the same categories, no basic science mechanisms. Instead, they learn some epidemiological associations that explain why these features cluster together. The students, again, do a study phase, much like the one they did in the other experiment. They complete a recall quiz, and then they do what we call an initial diagnostic assessment. So this is their ability to diagnose those 4 broad categories of disease. Then we challenge the students to learn something new. So this is our novel diseases. So again, they've learned the basic categories. Now we say, we're going to challenge you with something you haven't learned before. And so we now teach them 4 specific instances of those 4 broad categories. And in this case, we teach everybody the same material. We don't even bother to repeat the basic science again. This is just clinically focused instruction. They take a recall quiz, and then we give them what we call a preparation for future learning assessment, which looks at their ability to learn those novel diagnostic cases. So this here is really the whole point of basic science education. We're really testing this at its core. And what we see here, this is the data on the 2 assessments. What we see is no difference on the initial assessment, but our basic science group outperforms our clinical group on that preparation for new learning. So what this study tells us is that the integration of basic science can prepare students for future learning of related clinical content. So this is a really important finding because this is really the goal and the crux of the argument here, that it helps them create that foundation on which they can build new knowledge. So of course, I'm not going to share every single study we've already done, we've ever done. We've done a lot of this type of work. We've done this in neurology and rheumatology and surgery and family medicine in a lot of different disciplines. And we've played with the protocol in different ways that we can learn slightly different things each time. And so across all of this work, what I can say is that we know that integration of basic science leads to improved diagnostic accuracy. I can say that we know integration of basic science leads to better performance on complex cases. And there's a bunch of other findings that come along with this. And yet we continue, I would say, to disagree. So we still have, despite all these data and despite all of these decades of work, I would say we still have constant disagreements with basic science and clinical teachers. So the question I've always wondered, and I'm sure everyone else thinks when they read the papers, is if this was so easy to figure out, like, you've been fighting about this for 100 years, somebody runs a couple experiments in the lab, and you solve it. How did this debate even come to happen? And why do we continue to disagree about this, the value of basic science? And I think there are a few answers for this. And this is an important piece for you as educators as you're trying to tackle this integration issue. The first is that I think our assessments make underlying knowledge invisible. What you notice in all of my papers, no matter which experiment you read, I always have a series of measures at the end. So the students never just take one assessment. You saw here, they take a recall quiz, there's a memory quiz, there's a diagnostic test, there's a supporting test. And often in education, we design assessments that don't make underlying knowledge visible. If you design for rote memory, you will get rote memory. So, and one of the reasons I never show you the memory test in these experiments is because there's never a difference between the participants on a rote memory test. So you have to design the assessment to show and to make visible the value of that basic science knowledge. In this case, the diagnostic assessment is what always makes visible. And the difference between the diagnostic test and the recall test is the diagnostic test requires you to use the information to solve a problem, not simply regurgitate something that I just told you. So I think our assessments make underlying knowledge invisible. The other thing is that we're all experts. So one of the things I know about all of my basic science teacher colleagues and all of my clinical teacher colleagues is that they are hired because they are experts in their field. And when you become an expert in any subject domain, it does not matter what it is, expertise in any area fundamentally changes your perception of the world. And this is, again, back to my cognitive psychology roots. This isn't a medicine thing. This isn't an education thing. This isn't everybody at all times thing. And so when you become an expert, it really changes how you see the problems in front of you. And so I have here a demo that I'm going to try to do. I've never actually done this on the internet, on a not in-person session. So let's just give it a shot. I love to do this because I'm a psychologist. This is how we do. So we're going to do something called the Droop effect demonstration. What's going to happen, and you're going to feel weird doing this if you're by yourself in front of your computer, but it's fun. So what we're going to do is a series of shapes is going to appear on the screen in a column going right down the middle of the screen. Your job, and you have to do this out loud, as silly as you feel, it only works if you do it out loud and quickly, is to ignore the shape and simply identify the color of each object. Okay, so just go down the list on your own and you're going to identify the color of each object. And you're going to do it as quickly and fast as you can. Okay, so don't think about it too much. Just go boom, 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 boom. Ignore the shape, identify the color, go as fast as you can. Okay, so here we go. We're going to start right now. Okay, hopefully we're all doing it. Okay, on a scale of 1 to 5, I want you to rate yourself on how difficult was that. Okay, so you're naming the color. 1 is really, really easy. 5 is this was really, really difficult. Okay, so rate yourself and make a little note to yourself. You can even pop it in the chat if you want. What's your rating? Okay. And then we're gonna try it again. So the same thing's gonna happen. Ignore the shape and just say the color.
Verde, azul, verde, rojo.
And what you find is, again, so let's try rating it for yourself. Which one was harder? So on the scale of 1 to 5, what's the rating for this one? If you have to ignore the shape and just say the color. And I actually can't even see my chat box now, so it doesn't. But usually, I've lost the chat. But usually, this one is a lot harder, right? This is harder to do. This one's pretty easy. Usually, the rating is a 1 because color naming is not that hard. In this one, the rating tends to go higher. Why? Why is it more difficult the second time? It's more difficult the second time because the words get in your way, right? The words get in the way, and what you try to do is read, right? The reason I chose this demo, the reason I knew it worked, I knew it would even work if I switched it to Spanish. I know it will work because what I know everyone here can do is read. You're all experts at reading, okay? And when you're an expert at reading, you can't suppress it. It means that when you look at that word, you will read automatically. There's nothing you can do. It's just going to happen. When you're an expert at something, your perception of the world has changed. When we do this task with small children who can't read, guess what? They have no problem, right? Because they can just look at the object and name the color. No big deal. The word's not stopping them. The word doesn't get in their way, right? Also, little children, if anyone has small kids, are exceptional color neighbors, right? Like they're really good at color naming. If you have little kids, you walk around and they're just trying to learn about things, you're constantly saying, what color is that? What color is that? And they name it. Adults don't do that very often, right? I'm not asked to randomly walk around the world and name colors, okay? But I do read. What all this tells you is that expertise, being an expert basic scientist, being an expert physician, all of these things change your perception of the world in ways that you cannot suppress. You can't stop being an expert reader for this one moment so that you can do this task. Expert physicians also, an expert clinician can't stop being an expert clinician. So when I ask him if he uses basic science, he's going to try to report it, but he's always thinking the way he always does. And what we know is that expert physicians will often say, look, I don't use my basic science to solve clinical problems. But truthfully, an experienced clinician, they're not solving problems. They're simply applying routine solutions. They're just simply doing something in a very automatic way. And so if I go back and ask them to tell me how they did that task, I can't do that. No more than you can tell me how you color name or solve words. You don't know how to do those things. So an expert physician really can't tell me the solution. They just automatically bring their own lens to a problem. Similarly, our basic science teachers automatically bring their basic science lens to a problem, right? They're no different. So what we know from the literature is that the influence of basic science in clinical reasoning can be subtle and entirely unconscious, right? So just because you're an expert in the area, or actually because you're an expert in the area, it makes it very difficult for you to unpack and explain how that underlying structure is influencing your diagnosis. So even though we are all experts, I would argue that for education, what we really need is the viewpoint of a novice. You need to somehow go back and reconstruct the world as if you were that toddler who actually doesn't know how to automatically read. Our basic scientists, when they look at clinical practice, they can't help but see the role of the basic science. It just jumps out at them. And what we want is to override that and set up a situation where they're functioning and acting and seeing the problem the way a novice would. So we know from our own work that novices who receive integrated instruction can also start to develop some of these unconscious, subtle influences of basic science. They can actually start to show similar patterns of performance as experts when we focus on these kind of unconscious abilities. So those are some of the things that we know from the literature and some of the things that we should all start to question of ourselves. The last thing I want us to all really question is whether we really know what integration means. Do we really understand what the goal here is? And I think we don't. We don't really understand what it means, and we don't really understand what we're trying to do. So I have here one final experiment I want to talk about, which looked at trying to unpack this exact thing. What do we mean by integration anyway? And so this is a study that was done by one of my graduate students, Miriam Baghdadi. She did this work in oral radiology, but the work is highly relevant to medical education. And so what Miriam did is she had two groups of students. These are students who enrolled in our dentistry program at U of T, as well as the dental hygiene program at a local community college. They're in their second year. And she asked the students to learn 4 different categories of oral abnormalities, and they're learning to diagnose them from an X-ray. In this case, our two groups both learn basic science. So there's no featureless only group. Both of our conditions are going to learn basic science. The difference is the students in our integrated instruction group learn a really tightly interwoven story that tells them about the radiographic features. And after each radiographic feature, we immediately give them a basic science mechanism. The students in our segregated instruction learn all of the basic science up front, followed by the radiographic features. So it kind of looks like this. Again, so you can imagine like sentence by sentence, breaking it down. So in our integrated, for a single disease, they learn a radiographic feature, basic science explanation. Radiographic feature, basic science explanation. For the students in the segregated group, it's all the basic science sentences followed by the radiographic features. So that's kind of the difference between the two groups. The students have a chance to study the material, just as I've always described on our computer programs. They do a recall quiz. Then they get to their diagnostic test, and they're asked to diagnose 28 X-rays that they've never seen before. Look at the X-ray, decide the most appropriate diagnosis. They go away for a week, they return to the lab and do 28 cases they've never seen before and a recall quiz. So again, what I want to highlight here is that we are trying to reproduce in the lab kind of an integrated version and a segregated version of instruction. And I'm going to show you the data once again from the diagnostic test. And what we see in this experiment, our integrated version is in red and our segregated version is in green. And what you see is our integrated instruction condition outperformed significantly the students in the segregated instruction. What I want to highlight here for you is that in this experiment, our segregation is by seconds. Okay, so literally it's all the basic science on one screen, on one slide, and then you flip slides and we start to bring in the clinical. And what we see is even with that delay, we're already seeing a degradation of performance in that segregated instruction group. So imagine for a moment that this was in the real world and we had basic science content in first year, and we expect the students to link it to clinical content in third year, right? So if we couldn't get them to integrate it within seconds, what are the chances that students are going to spontaneously integrate content over years, okay? Over weeks, months, years? It's not going to happen, right? They couldn't do it over a couple seconds. So this is where this is what we call cognitive integration. It's this idea that we don't just want to have two things in close proximity in the curriculum. No. What we want to aim for is cognitive integration. It's an effortful mental activity. It's integrating the knowledge within the mind of the learner, not within the program. So it's not sufficient to say, I have an integrated program because I have both basic science and clinical present. No, that's not integrated. You could imagine I could set up a course. I could say I have an integrated course. My all of the basic science at the beginning in the first lecture, and then all the other lectures, it's the clinical teacher. Is that going to achieve the kind of cognitive integration that we're trying to aim for in the lab? Probably not. So I think that that fundamental definition of basic science is something that we definitely need, of integration is something that we definitely need to rethink. Are we really integrating? When I say integrated curricula, I mean cognitive integration. What do you mean when you say integrated curriculum, right? We all have to get on the same page. As we're thinking about that, I also challenge us to say, you know what else do we need to rethink? I also think we take for granted what basic science is. At the beginning of this, I kind of loosely define basic science as biochemistry, anatomy, physiology, but that might not be an expansive enough definition of basic science. So I have here a paper by Lucy. It's actually getting a little bit old now, but the paper looks at what we mean by basic science, what we mean by clinical science. And what Lucy argues for is a whole new set of clinical sciences and a new set of basic sciences to support medical education in this new evolving world of practice. So this is Lucy's attempt to bring in systems science, engineering, and a bunch of different other forms of science. And so we have now tested this as an extended, I'm just zooming in here on what she's calling basic sciences. These are all system sciences that we hadn't thought of before. And what I would argue is that all of these should be considered by all of us as basic sciences, right? It's not just biochemistry, anatomy, physiology. When you have this definition of cognitive integration, it allows us to change what we mean by basic science to be much more expansive. Any form of knowledge that can provide mechanistic understanding can be considered a basic science. It doesn't just have to be restricted to the ones we had before. Here's some other examples that Lucy is arguing for. And so we tested Lucy's model in the lab. And what we did was, I'm not going to run you through design, but the paper is right there in case you're interested in. And what we did was we said, well, if we change our definition of basic science, if we start incorporating sociology, if we incorporate, in that study, we used evolutionary psychology. And we were able to show that cognitive integration of these new basic sciences supports the development of coherent mental representations and preparation for future learning, just like we saw when we were using anatomy and physiology. So all of the things, hopefully we have some time left for discussion, we do. So really what I want you to kind of think about moving forward is, again, we're all educators, but we're all experts. And once you have expertise in a field, it becomes really, really difficult to unsee. And so that's why I think it's important to look at the literature, to look at the studies, to look at all the other things that kind of unpack the world for us, because we can't assume that our assumptions are correct. I also think it's important to keep in mind that even if basic science doesn't feel like it's useful, you know, when you ask the expert physician, when you try to look at your assessments, the subtle and fragile nature of basic science does not lessen its value. It is absolutely valuable, absolutely critical for medical education. And finally, I think that our instruction and assessment across undergraduate education and into postgraduate and continuing as well should always aim to foster integrated understanding. It's this idea that integration exists within the mind of the learner, not just the curriculum, right? We want our students developing that tightly integrated understanding of content. It's not sufficient just to fix our program. And I'm going to end there. I just wanted to really quickly thank some of the people who've done a lot of this work. So Miriam Baghdadi, again, one of my graduate students who has continued to do some of this work since leaving us a few years ago. She's at Kuwait University. Maria Malopoulos is my partner in crime. So Maria is my close collaborator. We do a lot of work together. You'll see her name on a lot of the papers, and I want to acknowledge that my work is her work as well. She also is a leading expert in theories around adaptive expertise, which is also, I didn't get a chance to talk about this, but it's also linked to the work that we talked about today. And we work together with all of our students in what we call the Excel Lab, which is education, expertise, cognition, education, and learning. And so we all work together on a whole series of studies, and I've included the website at the bottom. A lot of this work was funded by the Medical Council of Canada, so thank you to them. And everyone always asks me about the slides and always wants to know how I made them. And so my full disclosure is I don't make the slides. We have a multimedia person at the Wilson Center. His name is Doug Buller, and Doug makes all of the slides. So that's how he gets all the pretty images. I actually don't know how to do that, so don't ask me because I can't tell you how to make it. He doesn't make a thank you slide, so I always make one of these ugly thank you slides at the end just to toss it in there, but thank you to Doug for the slides. And yeah, that's all I have. I've also included my email address in case anyone has questions that we don't get to today, and also in case if you're looking for any of the papers and you can't track them down, then I can provide them. And I'm happy, Belinda, to share with you a copy of the slides, and then people
that would
can.
be great.
Yeah, I'm more than happy to do that.
So I have several questions, but first, Nicole, I want to introduce you to our dean of our faculty, Dr. Valdez, who has gladly joined us. Yeah.
Hi, nice to meet you.
Hi, it's a pleasure to be here at the hospital.
Thank you for having me.
And Doctora Silvia, she is dean and leader of this new style of teaching, challenge-based learning. I don't know if Silvia and Dr. Valdez, do you have any questions for Nicole before I start to talk unstoppably?
Thank you very much, Nicole. Congratulations for your presentation. I mean, this is one of most important topics to get together the team from the basic science, clinical science. So we are really glad for you having here all the faculty talking with you. So thank you very much again. I think this is very important information for all of us.
Thank you. Thanks for joining.
Thank you. Yeah, so Nicole, I think you mentioned a very important thing is that we as teachers, in some way, even though we are experts, we do all this subtle or subconscious integration. The thing is, how do we teach them to the students? Because, I mean, right now that we have started a year ago with this new style of teaching, one of the things that the students claim is that they cannot put together all the pieces, that they need the guidance. I mean, they are first year students, they just came from college, that they, even they complain, they expect us to integrate, but we do not know how to do it. So that is what I want to start to work with our faculty, because we have to do this in a more conscious way. Like how, as you said, it doesn't matter how you write it in the curriculum, is how the teacher works it in the class.
Yeah, that's the most important take home for sure. And I with students, it's so hard because when they say, well, we can't, and you're expecting us to do this, there's a tendency to feel like they're just trying to, they want you to spoon feed them and they don't really want to work. And so you can start to feel that. But when it comes to this basic science integration piece, I honestly feel for the students. You can't assume that they're going to just spontaneously integrate. They really, really won't. We know this from like decades of work in psychology, just basic psychology. The reason we were able to design that experiment, when you think about it, that's a really risky experiment because we had to recruit all these participants, go through all this work for really a difference of a few seconds. And I was pretty confident it would work because in psychology, we call it spontaneous transfer. And spontaneous transfer means that you just on your own independently link two things. And we know that that does not happen, right? It just doesn't happen. So you really have to spend time not expecting that integration activity to be something the student does on their own. You have to walk them through it. So either you can do it any number of ways. You can do it through just telling them, hey, this is the link, this is the integration. So I do all of my, let's say I was doing didactic lectures, then my lectures have to be integrated. At the moment, we have to think a lot more carefully about what our lecture slides say with the words that comes out of our teachers' mouths. Like that's where the integration has to happen, and you have to make it explicit. Now, if you're going to be doing something other than didactic lectures, which you can, I mean, I think this is amenable. The key point is to make sure that that integration component becomes the goal of the activity.
Yes.
And if it doesn't matter if the students are expected to come up with their own, that's fine, but then you have to scaffold them and follow up immediately. We call it a time for telling. So yes, the students struggle and they try to come up with their own connections, but there also has to be a time for telling. There has to be a moment where the faculty member says, this is the connection. The explanation for this clinical finding is this basic science manifestation, and it comes right afterwards. So I'm all for kind of discovery learning and opportunities for I'm all for guided discovery, not just independent discovery, but I'm very much for guided discovery. But then integration becomes the goal. That's the objective. And that's the challenge with any of these kind of active learning modalities, is that you can end up in a situation where the way the learning activity was structured, it was so focused on clinical. And then when you get to the assessment, you expect the students just automatically bring in the basic science, which they weren't going to do, right? So it's making sure that as teachers, that you're all very clear on the goal of the activity. I am a really big advocate for having teams of teachers build instructional materials together that can then be delivered by anybody on the team. So I think it's really important that if you're doing case-based learning, then you have teams of basic science teachers and clinical teachers that you build the case together, and then it can be delivered by anybody, right? It doesn't have to be the basic science. I don't think basic science teachers are the only ones responsible for teaching basic science. I don't think clinical teachers are the only ones responsible for teaching clinical. So I think as you're creating your cases, your problems, your challenges, I think it's teams, multidisciplinary teams, creating that material. And that will make sure you haven't missed anything.
And how about reorganizing the faculty? Because we have been talking about, I mean, for starting, that maybe one or two introductory topics, the clinical teachers can invite our basic teachers. I mean, just for starters, right? Because I think, as you mentioned, it should be multidisciplinary. But we face this kind of reluctance about the clinical experts saying, okay, I'm going to probably compromise 2 or 3 classes, which I have really to squeeze in to give them all the different main diseases they should know about in each clinical clerkship. What has been the experience at the University of Toronto? I mean, how to, as you mentioned, always the two horns, right?
Yeah. How are you going to do this together?
Yeah.
Yeah. And so I think there's a couple ways that you can go about this. I really think this takes, even a session like this, like I think it's very important that everybody kind of get on the same page here, right? So it's not just my course, even if it's been your course for 20 years, right? The point is that as we move forward, we want to trust our colleagues. We want to take a more team-based approach to teaching. And so what we've really found is that we have asked our basic science teachers and our clinical teachers to collaborate on case-based instruction. So the clinical teacher is not losing time. Okay, this is the key point. The clinical teacher is not losing time because the basic science is brought in service of helping to understand the clinical. So what I'm not going to do is say, you used to have 5 weeks and I'm going to take out 2 weeks and those are going to be basic science lectures. No, that's not what we're doing. We're asking the basic scientists to provide that mechanism that helps the students understand the clinical. So the clinical is still the focus. The basic science is in service to that. And so that's really kind of been our approach, is we always start with the clinical and we're bringing in a mechanism that helps you understand it, which usually means, and this is where right up until this point, all the basic scientists love me. And then we get to this point and they don't like me anymore. But it generally means that you are probably going to have less basic science overall, just content depth-wise. The truth is the basic scientists do sometimes go too much into depth. And that's what happens when you have an isolated basic science course that's not linked to anything, right? You'll go in depth in this one thing. Again, that's a function of your expertise. If you're an expert in basic science, you think everything's important and you will go really down to nitty-gritty detail, right? So we're trying to avoid that by saying the basic science. If you're doing integration properly, the basic science is used as a mechanism to help you understand the clinical.
Yes.
If you're doing it incorrectly, then that's what we call contextualization. And you're just using the clinical as examples of your basic science. That we don't want. So we're trying to avoid contextualization and we're aiming for integration. And if you do it well, and I'm not saying it's easy, it takes some effort and energy on the part of all faculty, but I do think it just results in more efficient education. But it takes some faculty development and some willingness to do things differently. Like there's no point in embarking on this whole thing if everybody just wants to do the same thing they were doing last year.
Yeah, I think that's something that we have to work on, because actually we use, let's say, like clinical vignettes when we do our exams. Yeah. And the students feel that that is like, oh, this is just to take my time out.
Exactly.
This is like rubbish I have to read in order to answer. And I think that that's what we have to work, as you said, because we are just using it as an excuse to introduce our topic, but not really telling them, you know what, you have, like, for instance, low sodium in diarrhea, which is a very common problem in pediatrics. Why do you have to understand the concentration between different compartments? Why do you lose it in one way? Why is it going to produce you brain swelling? But as we think it's something natural that is going to pop up in our students' head, it doesn't happen that way.
It does not.
Yeah.
That's a perfect example. That's a perfect, you don't want to just say, well, trust me, it's important.
It will happen some way or the other, right? And they just are frustrated. So I'm just going to stop right now because I can spend more time. So if anyone has any questions, you can just take out your, activate your microphone. I don't know, Nancy. I see Paola. Yeah.
Nancy?
Yes, please. Thank you very much for your lecture. It was really, really nice. All the information you shared with us, very interesting. How the comparison of the two groups is really dramatic. And about what you were mentioning, and Belinda also, I think it's very important for us to change this way of thinking, of this way of talking, that it's mine and it's yours, and that's basically, I think, something that we have to learn to, or rethink and relearn before we can move forward. So I think this could be an opportunity for us to think about maybe if we could get some other opportunity for us to practice this rethinking, or this unlearning and relearning a new way of communicating between us.
Yeah, definitely. I think that that's one of the biggest pieces, like the amount of energy that you can spend. Your time is best spent on faculty development, right? Getting everybody on the same page, getting everybody realizing we're going to do this, we're going to do it right. And that means you may have some people giving up some ownership of things, right? And that's okay, right? Like we can all stand to give up a little bit of ownership of things if there's going to be a big return in the end. And I think there is. So we took when we did our curriculum renewal, we completely reorganized our structure. We created brand new cases. We do a case-based learning, new cases. We designated new leads for each week. Like it was a big restructuring. And some people aren't, I'm not going to pretend everybody's happy. Some people were not happy with it. Some people are concerned they've lost face time with the students, all those kind of things. And those are valid concerns. Right. So if, for example, your promotions process is only based on face time with students, then yeah, that's not fair, because not everyone's going to have the same amount of face time with students. So you need to figure that out. So there's certainly pieces that come along with it that aren't the easiest. But I do think that that's the best way around it, is to spend some time getting the ownership model organized and just saying this is not a basic science course. There's no such thing as a basic science course and a clinical course. Like that we don't have anymore. We have a course and it's meant to serve the students. This is the clinical content area, but it's not a course that's owned by one camp or the other. And we don't measure our contributions in terms of weeks or time or anything like that. We are looking at knowledge.
Yeah. But for example, I mean, because one of the things we're also concerned, right, is that you work with a new curriculum, of course, to improve the knowledge of our students and also to make this recall memory much more efficient. Let's say it that way. But at the end, they will have to. We have also the same as the USMLEs to apply for a specialty. And sometimes we want to make this intermediate assessments to know if we are in the right track, and not after 6 years say, okay, we think we lack to show you, I don't know, a certain way of getting to a proper diagnosis or identifying the proper pathological mechanism. So how do you suggest for us to have like this intermediate assessments to know if we are pushing our students towards where we want? Because one thing is what we want and the other thing is what happens to them.
Yeah. So I think that the way you can set this up, we've done this at U of T, McMaster has done this, a bunch of other schools have done that. It is setting up like progress testing and getting people to have we have two devices. We have progress testing and we have a learner chart. So progress testing is a test that everybody has to take at routine intervals. That test is designed to think about what's your end goal, whether it's, for us, it's a licensing exam. So we know that the content areas are going to be on the licensing exam. The progress test is something all the students have to take, and we watch their progress. So we expect it's not going to be, it's not evaluative for them. So if they fail the progress test, it doesn't matter. It's literally for us as an institution so that we can see how everyone's doing. And we actually anticipate that many students in first year will fail. We expect you to fail that. What we want to see is the progression. We want to see that over time they're getting better, they're getting better, they're getting better, they're getting better. And that's what we look for. And so we set up situations within our curriculum where the students are taking assessments that are predominantly for us to monitor. And all of the students also have a learner chart where all of their feedback is all localized, and they have an academy chief that meets with them to look at their overall, all of their performance, and meets with them and says, oh, we noticed that we have a lot of formative quizzes and stuff like that. So they'll see those things in the chart and we can work with people who are falling behind.
And the assessments, are they the same from first year to
Yes.
fourth?
So the progress test is designed to basically stay the same. Like the questions change, like because it's an item bank and we don't want people to share it. But overall, it stays the same, and it's the same for everybody every year. So everybody's sitting the exam at the same time, and they're all getting the same questions. Our expectation is that our year fours are going to do better than our year ones.
Okay.
But we're watching how they go through, and that's literally. And I do think that's very important. If you do have any high stakes external exams, you want them prepped for those.
Okay. Okay. I don't know, Nancy, Sylvia, Mildred, anyone from the audience that wants to make questions to Nicole?
Yes, Melinda, I will ask.
Yeah.
Thank you, Nicole. I really enjoy your talk, and it's been very insightful. Well, as a dean, Euro Insurance, a lot of the things that we are doing as a team. So thank you very much for that. For example, this about the progressive test, we have it in place. We have the master one, and at the same time, we have like points of like gatekeepers, the International Foundation of Medicine. Well, but I want to ask you about the expert thinking. Because we are training a physician, nutritionist, dentistry, and other health professionals, and then we want them to become experts. So I really was intrigued, and that's true. The way we see the things is because the expertise that we achieve, novice, middle career, or really an expert. And talking about that, most of my teachers or most of these guys will be clinicians. Can you talk a little bit about the different clinical thinking or clinical ration, the way you approach things?
Yep. So I think that the construct, and I didn't get a chance, this is a great question because I didn't get to really expand on it too much in the talk, but the overarching construct that we work on when we think about expertise is adaptive expertise. And so our goal is to really, adaptive expertise is essentially focusing on this idea that an expert in any domain, dentistry, whatever area it is, an expert is constantly balancing this need for efficiency and innovation. And so an expert is an expert because they're able to solve routine problems quickly, efficiently, safely. So when it's a problem you've seen before, you should be able to just go. You know what to do, you apply the right solution. But then you also want people to be able to create new knowledge and to create new solutions in the face of something they've never seen before. And adaptive expertise is a theoretical model by Daniel Schwartz that accounts for both aspects of this. And so what he argues is that your goal as educators is not to produce somebody who's an expert. It's to produce someone who at the end of their training is able to create new knowledge in the moment when they hit something they've never seen before. And so I think it's a really great, that's why in my talk, 2 of the studies are called Preparation for Future Learning. That's a key capability of adaptive expertise. It says there's no way that the school is going to be able to prepare you for every possible problem that you're ever going to face, right? There's going to be a lot of stuff that you're just never going to be, that you're never going to have a chance to see. And so our goal is to prepare whoever it is to be able to create new knowledge in the moment. And so it's how well can you handle novelty? How well can you handle complexity? How well can you handle ambiguity? Those are the things we want to look at in medical schools, and that should be kind of the overarching theme. So when we think of adaptive expertise, that's literally what we're thinking about. It's this ability to be quick and nimble when a routine problem comes up, but then also to create knowledge and new knowledge in the face of complexity. And I think that's a construct that works really well across all of the health disciplines. And it's nice because it also has a lot of accompanying pedagogical tools that have already been tested in the literature that really work to support it. So it's a really good construct for understanding all those different disciplines.
Thank you.
Thank you very much.
Nicole, I think we're over time, right? Because you have something else?
Yes, I have something else, but
Okay.
This was fantastic.
Yeah, so thank you so much, Nicole. I hope that we can invite you in the future because we're still building this curriculum. I really appreciate also that you have allowed me to record this session so we can also make a little, invite much more teachers that are involved in this curriculum with us. And thank you so much. So we'll see later.
Thank you. Thank you all. Have a good day.
Bye.
You too. Thank you very much, Nicole.
Bye. Thank you.
Thank you very much.
Thank you.